So welcome again, everybody. We're delighted to co-host this symposium with Out Melanoma. And I'm going to talk about what's happening in the field, if I can advance the slides. Okay, so just to get us going, I'm going to talk about a little bit of melanoma incidence, the number of new cases we see per year, as well as mortality, the deaths that we see. So there will be over 100,000 cases of invasive melanoma this year in the United States. Most of those are occurring in white individuals, though we are seeing an increased burden of disease in people of color who tend to present with more advanced tumors. Melanoma right now is the 5th most common cancer in both men and women in the United States. It is not, though, a leading cause of cancer death when we compare it to breast, colorectal, prostate cancer, etc. That being said, we've seen, as a melanoma team, we see many patients who succumb to melanoma. In fact, it's estimated that about 2 individuals in the United States die per hour, including melanoma and other types of skin cancer. So there's a lot of work for us to do. And as I mentioned earlier, it's only been in the last decade that we've seen the mortality rates, the death rates from melanoma begin to decline due to better therapies, immunotherapies, and advanced disease. Okay. Sorry, this is just not, it's intuitive. Okay. That's not moving. Sorry. Is there a way to do it here? Okay. Oh, all right. Okay, so it's this one. All right, we're getting here. Sorry, folks. All right. So when we talk about precision medicine, we're talking about sick care. We're talking about therapy that we give to treat active disease. When we talk about precision health, though, we're actually talking about disease prevention. And this can include a number of facets. So prevention, we think about reducing harmful exposure to the sun for melanoma and other skin cancers. But we also want to think about legislation. And Out Melanoma was really critical in trying to reduce tanning bed use by minors in 21 states and, in fact, prohibiting it. And we want to get to that point where we ban tanning beds entirely, like has been done in Australia and other countries. When we talk about early detection strategies, we're not talking now just about telling patients and providers to look at the skin, but we want to empower consumers. We want to put tools in their hands so that they can look at their skin, know what clinical warning signs are, perhaps use a smartphone app with validated AI to help triage into the right specialists, use telederm to get into care early, and detect that melanoma as thin and early as possible so that we can effect cure. Sorry, these slides are still not advancing. Okay. When we talk about primary prevention in general, it's estimated that if we were to enact sun exposure behaviors before the age of 18, we could prevent about 80% of non-melanoma skin cancers, at least in people as they get older, which would be huge because we see over 6.1 million cases of basal cell and squamous cell carcinomas per year in the United States. And a lot of people get that sun damage early in life. So what Don Siegel is doing to try to enact primary prevention campaigns in the adolescent years is critical. We know from a large Australian study that melanoma can be prevented by using regular sunscreen and other sun protective measures. But in reality, we have real challenges related to our U.S. sunscreens and protection from the sun. So just to give you a real brief primer on radiation from the sun, ultraviolet light accounts for only about 6% of the sun's energy reaching the Earth's surface, with the vast majority being visible light or infrared light, which have much longer wavelengths and really can't be prevented much in the way of sunscreens. Just protective clothing would be helpful. In terms of harmful ultraviolet light, again, which is relatively low percentage of the sun's energy reaching the Earth's surface, the UVB and the UVA rays are the critical ones that cause skin cancer and other photo damage, photoallergic reactions, and so on, cataract formation and such. And we're looking at UVB light and UVA light that extend from 280 to 400 nanometers. One of the difficulties we face in the United States, though, is the efficacy of sunscreens. And this has been a long-term frustration for many of us in the melanoma prevention and control field. And in reality, there are many better filters available around the world that go to that far UVA spectrum, 400 nanometers, and do a much better job in preventing harmful UV radiation and ultimately skin cancer. I put this list of slides or ingredients so that you can recognize them when you hopefully purchase these from abroad, which is what I always recommend my patients do. And they have trademarked ingredients called Tynazorb, Tinosorb S and Tinosorb M, Mexeril, there's varieties of that, Uvenol, varieties of that. And now there's even a new one called Triazorb, which is out of Europe. These are all Europe and Asian markets and such. These are sunscreens that are actually going to go into that early visible light spectrum for the first time. And that's important as we see a lot of pigmentary change occurring in that blue light spectrum that's between 400 and 400 nanometers. In the US, the only effective sunscreen we have chemically is the avobenzone. It goes to 370 nanometers, so it's not reaching far UVA light. It is photolabile, meaning it breaks down in the sun. Go figure. We don't want a sunscreen that breaks down in the sun. And it really isn't as effective. And so mineral sunscreens themselves, which reflect and deflect light, are also not really hitting that. So it is, we believed, and we very much hope after a 22-year effort to get these superior filters into our sunscreens, that at least the Tinosorb, bumetrizanol, which is the bedrock of European and Asian sunscreens, will be in the US market by the end of 2025. So fingers crossed. I'm going to pivot now, though, to survival by melanoma thickness. So when we look at melanoma as a cancer, it's considered the most deadly because it's only a minute fraction of tumor difference that makes a huge difference in survival. We see a patient with a hairbreadth thick melanoma, that's about a millimeter, surviving at about 98% at 10 years. We add 3 more millimeters to that, a 4 millimeter tumor or greater, a T4 melanoma, we'll call that. Survival drops to 75%. So there is a strong rationale to detect these tumors when they're flat, they haven't metastasized to the lymph nodes in the bloodstream, and they're more curable. The problem is, of course, we've got a visible cancer. Why can't we pick this up when it's, again, a thin tumor? And we've done work at Stanford to actually look at what's happening with thickness-specific incidence trends. This is using the large National Cancer Institute data, the SEER cancer database over 8 years, over 180,000 patients. And we looked at thicknesses of melanoma according to age, patient sex. We looked at socioeconomic status as well as race and ethnicity. And what we see is that the thickest tumors, those T4 tumors, are continuing to rise at about 3% per year in the United States. And the burden of that is particularly borne by people of color. So we're seeing this in Black and Hispanic individuals, along with individuals of low socioeconomic status. So there's a real rationale to try to reduce these more lethal, deadly melanomas and target the populations in whom we see those elevations continue. We need to better target our communications about melanoma. We know it's rarer in racial and ethnic minorities, but they're 2 to 3 more times likely to die from disease than non-Hispanic white patients. We still direct much of our messaging regarding early detection and prevention to higher SES white individuals. And we need to refocus some of the messaging to include people of color, understanding that they're at risk for melanoma, though the risk is lower, but understanding what it looks like when it occurs so that we can detect disease earlier rather than later. And this is a picture on the left of the 4 melanoma slides I have over a 30-year career that are the thinnest, flattest, and you can see they're not that flat, thinnest melanomas I see in people of color. We call this Fitzpatrick skin types 4 through 6. Most of the tumors we see in people of color occur on the acral areas, which Alex is going to talk about a little bit later. And this is the palms, the soles, fingernails, and toenails. And most of the time, these are unrecognized. It's treated as a fungal infection. Someone stepped on a nail. They have a bruise on the foot. So we really need to, again, improve that awareness as opposed to the typical messaging you see on the right, which is very busy, related to the ABCDs of melanoma and people with lighter skin or moles, which is still relevant, but we need to kind of share this messaging for aquamelanoma. In California, we started the Wipe Out Melanoma California statewide initiative, and we launched this 4 years ago at the height of the COVID or the beginning of the COVID pandemic. But our goal is to really target these highest risk groups in the state of California to combat lethal melanoma, the thicker tumors that we see continue to rise. And we want to lead the way in prevention, community outreach, and novel diagnostics. We've developed a collaborative network of research institutions, community stakeholders, to really reduce health disparities. We want to do this through leveraging novel technologies, including augmented intelligence and AI. We have a melanoma community registry of California that we're using to try to enhance the community engagement, have patients participate in our outreach efforts as well as early detection efforts. We're partnering with Oregon Health and Sciences University War on Melanoma, which has a wonderful public health campaign in their state. But Oregon's a very different state than California. It has about 1/10 of the population. And we are much more mixed in terms of our racial and ethnic mix in our state. We want to serve as a model for states that have similar socio-demographics, so that same mix of the population, the same sunny climate, and so on, and particularly the same incidence of melanoma. And then we want to share these materials. So our coalition of academic and health system partners is broad. Again, we are the hub. We started this program. We're working with our partners at Cedars-Sinai, where there's a wonderful Center for Health Equity and Cancer Research. We work with the UCs and the UC Cancer Consortium. We work with Sutter and Kaiser and the other melanoma centers around the country. But you can see, looking at this map, that all of the academic and melanoma centers in the state of California are located in the big cities on the western coast. So we have a very difficult time reaching the more rural populations and counties that are in far northern and eastern California. And why is this relevant? Well, California has the most melanoma of any state in the US. We're the most populous state, so we have the most melanomas. 11,000 new cases of invasive melanoma this year, compared to the entire country of Australia, with about 16,000 cases. There's a lot of work for us to do to try to prevent disease, treat it early, get patients into care on trials, and into our oncology and surgical oncology specialists. We've got to think about different ways to deliver care and provide care in terms of AI and AUI and teledermatology. So beyond our early detection strategies and creating culturally and literacy adapted materials to reach populations in need, we have to really think about the school-based prevention efforts as well. It's been said by the CDC at least 10 years ago that if we were to enact significant primary prevention campaigns with sun protection, we could have averted about 230,000 cases of melanoma this decade with up to $3 billion in initial treatment costs. That's not for advanced disease. That's prevention and first-year treatment costs. So I'm really proud that what the work that Dawn is doing and pleased to be part of it. She's going to talk to you about the creation of ways to reach our younger patients, our younger individuals, I should say, the adolescents who become more resistant to sun protection messaging. How can we reach them in ways that are meaningful to them, particularly with sort of the gaming mentality, virtual and augmented reality? She'll talk about this during what we're trying to do with sun protection education. This is just a picture of our Melanoma Community Registry of California. We've got this translated into Spanish with the goals to translate this into other languages in the state to reach populations in need. And I'll just briefly allude to the fact that we've done some qualitative work to really help us understand the barriers to awareness, prevention, and early detection in populations, non-white populations, the Latino population in particular, which really accounts for 39% of our state's ethnicity. So we really got to think about really looking at the burden of disease, where it's coming from, who's presenting with what types of disease. And we found when we did this qualitative study with focus groups, which again, luckily we completed right before the pandemic started, that of course, access to primary care, dermatology and oncology services are barriers in rural setting, but skin phenotype, the type of skin you have, the skin tone you have can really be a major issue in terms of perception of your susceptibility to melanoma. In people of color, we see lack of trust in the healthcare system. We saw this with COVID vaccinations. And then there's a real issue related to lack of self-efficacy or advocacy to really advocate for yourself, to get into care, to understand what a tumor looks like, what a warning sign is, how to get into the right specialist. And those are some of the things we're really trying to combat in the Wipe Out Melanoma California campaign. We are now working with community health workers in our federally qualified health centers to pilot educational materials. These are translated into informal Spanish, and we go through a lot of vetting of these materials to make them understandable, less intimidating in terms of the scientific knowledge, to try to get people to understand what warning signs look like, and now work with community health workers and other providers to get them into care. And we need the same tailored messaging in Black people. This is another focus group qualitative study that my colleague Eleni Linos conducted, again showing that the awareness that melanoma is a skin cancer and that it can occur in Black people is low. And we need to really highlight that the high-risk sites that it occurs, again, the palms, soles, and the nail beds. About a year ago, we were asked to do out of Stanford the JAMA patient page. JAMA is the Journal of the American Medical Association. It's the most widely read medical journal in the United States. And we are pleased to participate and do this page once again. But we revised it significantly. We're still, again, including those ABCD criteria for melanoma in people with lighter skin or many moles. But we're also including that aspect of clinical warning signs of melanoma on palms, soles, and nail beds, particularly for people with darker skin. Right now, our Wipe Out Melanoma California campaign is looking at engaging nail salon technicians, both in the beauty schools. There's the California Institute or Board of Barbering and Cosmetology, along with the California Healthy Nail Salon Collaborative. And this would really help us, we think, to really look at acromelanoma detection across the board. Acromelanoma is detected late in people, regardless of their race and ethnicity, skin color. It just is a less recognized type of melanoma that occurs, and it can be very difficult to treat. It turns out that there are 500,000 licensed nail salon technicians in the United States. 100,000 are in California, 20% of the workforce, and that the English proficiency is quite low. Only about 50% have enough English proficiency to really talk to clients. And so working with the Healthy Nail Collaborative and others, we're going to try to educate, particularly the Vietnamese speaking groups and Spanish speaking groups, to understand what to look for in the nails, and then hopefully engage their clients in this. And Impacted Melanoma is a wonderful group that's out of Boston. They're a nonprofit. They've done quite a bit with hairdressers and stylists to recognize melanoma on the scalp. And we're now piloting and pioneering this work with nail salon technicians. One slide on AI, because my colleague Albert Chu is going to talk about this. Stanford has really spearheaded some of the AI works globally. And we had one of the seminal papers back in 2017 showing that artificial intelligence-based machine learning algorithms could actually help us detect skin cancer. But we've learned a lot since then. That's been very humbling, and Albert will share that. AI is a wonderful potential, and we've got to figure out where it fits into the milieu of melanoma, early detection, prevention, how we can predict responses to therapy, immune toxicity, and so on. We have our Stanford Translational AI and Dermatology trained team, and our goals are really to advance clinician-driven, patient-centered, responsible, augmented intelligence. So AI that augments our clinical decision-making, doesn't replace what we do. And we're really happy to see what's happening in the field as we move forward. So I'm looking forward to Albert's talk on this. Finally, we have vector demographics, total body mapping, and this has really changed the way we're following patients. There are a number of different types of looking at patients, but this is where we can potentially incorporate AI to help us in clinical decision-making, do less biopsies on harmless lesions, do the right kinds of biopsies on more lethal melanomas and not the indolent melanocytic lesions that would never do a patient harm. And even incorporating AI to change detection will be part of that process. So we're excited about this. We offer this at Stanford for our patients with atypical mole syndrome. It's become part of a standard practice. We're expanding our vector demographics across the Stanford network of dermatologists. In terms of melanoma early detection's future, it's bright. I mean, we really want to think now about screening genotypic patients according to their genotypic, molecular, and phenotypic risk. We want to target those high-risk patients based on their family history, genetics, mold type, et cetera, with state-of-the-art total body mapping and imaging, and then integrate augmented intelligence and machine learning to help us, again, really provide the best care in terms of early detection of more relevant tumors. And in this way, we can still also want to get these patients into care in terms of our oncology side, our surgical side, our trials. So all that we do with early detection, prevention, and community outreach is really trying to engage the melanoma patient population and their loved ones and being active partners in the system. And so we're very pleased with what's happening with Wipeout Melanoma California, and I really invite you to join the wave if you haven't. We're looking forward to, again, piloting some of our novel technologies in the near future that help us with early detection. And there's materials about this in your folder. So my apologies for the AV back and forth, up and down. I hope that went smoothly enough, but we will talk more at the Q&A, and I want to introduce Albert to come on up and talk about AI. Thank you.